podcast, NRSNG podcast number 201. What's up, everybody? This is John with the NRSNG.com podcast. I feel like it's been a while. I feel like I've been, haven't been on the podcast as much as I'd like to lately. But today I have something that I'm really excited about. We're going to talk about 10 cardiovascular diagnostic studies. The reason I want to talk about this is you don't really get a chance to see a lot of these while you're in nursing school, and depending on what floor you work on and where you end up as a nurse, you may not see a lot of these tests done very often. So I want to give you guys a chance to hear about some of these tests, hear about why we do the tests, and some of the comments and some of the nursing care related to these 10 most common cardiovascular diagnostic studies. Before we get started, guys, I want to thank you so much for being here. Thank you for being a part of the NRSNG family. The podcasts have grown tremendously. As you know, we have 5 different podcasts. We have the Mnemonics podcast, Labs podcast, Meds podcast, Struggling Students podcast, and Question of the Day podcast. And then we have this NRSNG podcast where I talk, basics of clinical nursing and how to survive school, the politics of school, all that. So that's really what we do here. The other podcasts are a bit more focused on different areas that we see you guys struggling with the most. So no matter where you are, guys, listen, I love podcasts. I listen to podcasts most often when I'm driving around town, or a lot of days I wake up early, go for a walk or go for a jog, put a podcast on. So wherever you guys are at, I thank you so much for listening. I thank you for being a part of this. And I thank you for helping us grow this podcast and reach more people. If you guys have a moment, head over to your email and hit us up, contact@nrsng.com. Love to hear from you guys. You can hit us up also on social media, NRSNG on Facebook and Instagram, or NRSNG.com on Snapchat or Twitter. All right, so we're everywhere on Instagram, on social media. We're NRSNG.com over on Pinterest as well. So love to hear from you guys. Thank you again for being part of this family. Thank you for helping this grow, and thanks for sharing with your friends. If you guys do leave us a review in iTunes, we'd love it. We'd love to hear them, or on Google Play, wherever you're listening. So with that being said, let's talk about these 10 cardiovascular diagnostic studies. The first one we're going to talk about is a cardiac biopsy. A lot of you already know just by the term biopsy kind of what we're doing here. What a cardiac biopsy does is we actually insert a needle and we pull out a sample of the cardiac tissue. Okay, we want to biopsy that tissue. The reason we do it a lot of times is to evaluate tumors. So if for whatever reason we notice a tumor on the heart, we're going to biopsy that tumor. We're going to put a needle in there and try to get a sample of that and biopsy that tumor. The cardiac biopsy can also be helpful in identifying the effects of cardiotoxic drugs. If we give a patient a medication that could be damaging to the heart, we can do a cardiac biopsy, to determine what are the effects of this drug on the patient. So those are the 2 main reasons we're going to do it are for tumors, evaluate tumors, assess tumors, and then also to evaluate the effectiveness or the effects of cardiotoxic drugs. We'd also use it possibly for cardiomyopathy or inflammatory heart disease. Some things to keep in mind with a patient who gets a cardiac biopsy is you want to watch very closely for any sort of perforation of the cardiac tissue, especially looking for cardiac tamponade. So while you may not see this very often, this is an important one to understand and to know. The next test that I want to talk about is cardiac catheterization, or you'll hear it a lot of times as cardiac cath. Okay? The reason that we do this is we do the cardiac cath to determine severity of arterial stenosis, okay? The cardiac cath also allows for a lot of different procedures. It allows for angioplasty, for arthrectomies, for stents. So a lot of times, like if you have a patient who has occluded coronary arteries, what we can do is we can do the cardiac cath. Basically what the cardiac cath does is we can go in through the radial artery, or we can go in through the femoral artery, and the physician, the interventional cardiologist, can put a sheath in there and then direct the catheter all the way into the coronary artery that is occluded, and they can then put a stent in there that will open up that portion of the blood vessel, allow blood to flow again, as a preventative measure for heart attack. Okay, we have a patient who has these occluded arteries. We can go in and do a cardiac cath and prevent that from occurring. So this is a really important one to see and to understand, because you will see this a lot. You'll see patients who have caths or have had stents placed, and you're going to need to know how to handle these patients and what to expect with these patients. So before a cardiac cath is done, it's important to check your patient for any sort of allergy to shellfish. Why are we going to do that? You guys know that when we use dyes for radiography type studies, it's important to understand if the patient is allergic to shellfish, because the patient could, if they're allergic to shellfish, these dyes can cause an allergic reaction in the patient. So you want to make sure they're not allergic to any iodine or shellfish prior to doing the test. After the test as well, you want to make sure that the extremity that was used, so whether you used the arm or whether you used the leg, you want to make sure that extremity stays straight for 6 to 12 hours, and you want to assess distal pulses in that area, because we can develop a hematoma, and then we'll lose blood flow distal to that area. So for example, if it was done with the femoral artery, you want to assess pulses in the pedal pulses. Okay, you want to make sure that blood's still flowing down there, that we're not developing any sort of hematoma, and that the patient is still getting all the blood flow they need. You'll also want to make sure the patient is able to move their hands, move their legs, move their toes, depending on whether it was used, an arm that was used or a leg that was used. And you want to make sure they still have that neurovascular function. Okay, did we do any nerve damage when we were in there catheterizing the patient? So you want to make sure they can still move their fingers, still feel, just as they could prior to the test. The next one I want to talk about is chest X-ray. Chest X-ray, you guys all know what a chest X-ray is. You've seen chest X-rays done probably, but let's talk about why you're going to see this for a patient in the hospital, especially when we're talking about for cardiovascular reasons. A chest X-ray is going to help us determine size and shape of the heart. It's going to help us know location. It's going to help us really know what's going on. So, for example, we would be able to tell cardiomegaly through a chest X-ray, and then we could do further evaluation. We could tell placement. We could tell if there's any fluid in there through a chest X-ray. It can also help us notice how pacemakers are doing. If a patient has a pacemaker or a defibrillator, it would help us know where it's located, if it's moved, or what's going on with the pacemaker. Basically, with these chest X-rays, we're going to be able to really look at the lungs, look at the heart, and really see if there's any gross abnormalities that we can see on this type of imaging, and then we can tell if we need to do more evaluation or if we need to do further intervention for the patient. Another test that we can do with our patients is a CT. Okay, we can do a computed tomography is what it's called, or a CT scan, and we can look closer at the heart and get a much more detailed, much more focused exam on the heart versus what we would get with a chest X-ray. So with a CT, we can actually assess for aortic dissection or aortic aneurysms. We can assess for myocardial infarction and cardiac tumors. We can also really see and assess the left ventricular wall motion. But a lot of times what we're going to use this for is to assess these aortic dissections. Those aortic dissections are where the intervasculature, the interportion of the vessel of the aorta is going to be pulled kind of off and away, and that's going to make that aortic wall much weaker. So we can use a CT scan to really see and assess that, and assess if that's happening, if that's occurring, how emergent is it? Okay, so that's really the use of a CT scan, or one use of a CT scan for our cardiovascular patient. And again, if the patient requires dye, it's important to assess if there's any sort of allergy to any types of dye. Otherwise, it's a pretty non-invasive procedure. The patient doesn't need to be sedated or anything like that. They'll just go in, lay on the CT scanning table, a scan will be done. It's pretty quick, and then the radiologist will be able to look at it, and the cardiologist will be able to look at it. Another one I want to talk about is echocardiography. Specifically, I want to talk about transesophageal echocardiography. Okay, so what this is to get the echocardiogram. So basically what the echocardiogram does is it allows us to assess the chamber size, wall thickness, valve functioning, everything of really what's going on in the heart, and gives us kind of more of a motion sensor of what's happening. So rather than just getting a simple view of what's going on in the heart, we can get more of kind of what's happening as the heart functions, as the heart moves. So it really helps us tell how are the valves working, how are the walls of the heart, and are there any dysfunction or abnormalities with the way that things are actually working and moving. So for echocardiography, like I said, one of the ways that we can do this is through transesophageal echocardiography. This is also known as TEE. That's how you're going to hear it, as a TEE. Okay, transesophageal echocardiography. Okay, and the way we do this is we actually place our transducer in the esophagus. Okay, so the patient needs to be... So it's much more invasive than just a regular echocardiography where we can do it over the chest. But for patients that are obese, or for patients that have COPD or any sort of chest trauma, or incredibly thick dressings or anything, it's much easier to get an actual image if we place the transducer in the esophagus. So we actually go in through the mouth, in the throat, to get this image. Okay, we don't do it externally. We actually go in and get this image. Now this can be a little bit scary to a lot of patients. It's kind of a weird sounding test, but to get the view of the heart, we actually go into the esophagus, and then through there, it's very close to our heart. We're able to get that view of the heart that we need. Now, anytime we're messing with internal organs, of course, we want to be assessing for perforation. So as we place that transducer in the patient's esophagus, it's important that we assess our patient for perforation of the esophagus, that we need to assess for sore throats, dysphagia, or any sort of pain in the esophageal region. Another test I want to talk about is the EKG, electrocardiography. This one is one that I know you're already familiar with, you've seen, and we talked about in greater length. We even have an EKG course that covers this. But I want to talk about what an EKG is. So EKG, I know you're familiar with EKG, electrocardiography. We actually have a whole course covering EKGs, and we talk about it a lot in depth. What I'm going to talk about here is just the basics of an EKG. First of all, it's important to understand that an EKG only tells us the electrical activity of the heart. It doesn't tell us anything about the mechanical activity. In fact, to get the mechanical activity, that's what we use some of these other tests for, this electrocardiography, the CT scans and all those types of things, where with EKG, all we're getting is our electrical activity. But we'll hook our patients up to these EKG and we're able to see what's going on electrically within the heart. So that's why it really gives us a good idea of electrolyte abnormalities, and it can hopefully correspond with our mechanical function as well. So for example, if we see a patient in VTAC, that's the first thing we always do is we go and assess for a pulse, okay? VTAC doesn't tell us that the patient doesn't have a pulse. It tells us what the ventricles are doing, okay, but it doesn't tell us what's actually, it tells us what we think the ventricles could be doing, but it doesn't tell us if we're getting any actual output and if we're getting an actual pulse. So we use EKG to assess cardiac electrical activity and assess for dysrhythmias, blocks, drug toxicity, electrolyte imbalances, and it's important that you place the EKG leads appropriately. Like I said, we have a whole course that covers this, but you need to make sure you place the leads appropriately and you're alert to what's going on with the patient. If you have a patient hooked up on the monitor, an EKG monitor, make sure you're assessing that and watching it close. Another one that we have that's closely related to EKG is a Holter monitor. A Holter monitor is a monitor the patient can kind of take with them. It assesses their heart rhythm over a long-term period, so they can kind of take it with them. And we'll do this if we suspect our patient will have EKG abnormalities or dysrhythmias over the period of a day or 2 days. And so what we'll do is we'll place the patient on the Holter monitor, and then we'll assess, did they have any dysrhythmias over that time? And then we'll monitor, okay, did they have any dysrhythmias and what happened over the course of this 24-hour period? We really want the patient to also be keeping a very tight diary and journal. And the purpose for this is if they notice any chest pain, they need to write it down what time they felt it. And then what we can do is we can go back and compare the reading from our Holter monitor with their journal. And we can say, okay, at 1 o'clock they said they had chest pain. Well, sure enough, they were having palpitations at that point, or, they were having PVCs or whatever happened at that point. And so we really use it as kind of like a diary for what's going on with the patient over an extended period of time with their EKG, basically. The next one we want to talk about is pericardiocentesis. The reason we do this, okay, what a pericardiocentesis is we basically insert a needle into the pericardium, into the pericardial sac, and we withdraw blood, pus, or anything that could be collecting in there. Okay, so what can happen is in our pericardium, we can get a fluid buildup, okay? So we have that lining around our heart, and if blood or pus or whatever fluid starts to build up there, it can start to compress our heart. And so what we have to do to relieve that pressure is we have to actually insert a needle, get it into that little area, and we have to withdraw that fluid, whether that's blood, pus, fluid, whatever it is. So it's really important that we watch our patient with this. We can, obviously, as we're inserting that needle there, we're getting close to the heart. The patient's having a buildup of fluid, and so it's really important that we're watching very closely for any signs of cardiac tamponade. Cardiac tamponade basically is compression of the heart from buildup of the fluid in the pericardium. So if that pus or blood or whatever it is starts to build up, it can actually compress the heart and then impact our mechanical function. Okay, so it's really important that we watch our patient for cardiac tamponade, and we need to assess our patient after this to see if the pressure was relieved, if the patient's feeling better. But pericardiocentesis is really just inserting that needle through the chest into the pericardium and withdrawing that fluid. Another one I want to talk about is called a stress test, or the stress echocardiography. What happens here is basically we hook our patients up to an EKG, and then we put them on a bike, on a treadmill, or whatever it is, and we push their heart to a point of dysrhythmia, basically. So we want to see how the heart functions and what happens to the heart as we start to work it. Now remember, what happens with the heart is it requires a great amount of oxygen, okay? And oxygen comes from blood, And so as the heart starts to work, as the heart starts to beat faster, it's going to require more oxygen. And if we have occluded arteries, or if we have anything else, any abnormalities going on with our heart, it's going to become very stressed, and we're going to start seeing dysrhythmias as we put the patient to this level of stress, this level of exercise, okay? So we hook them up, we put them on a bike, have them start biking until we start seeing the dysrhythmias, and it really gives us a way to assess for coronary artery disease, coronary syndrome, things like angina, things like that. We can really take our angina, what's going on with this angina, and look at what happens as the heart is stressed. So that's really why we do the exercise stress test. That's why you'll see it most often for your patients. There are other reasons it's done, but a lot of times you'll see it as a patient goes to cardiologist and starts becoming assessed if they have any sort of angina or anything like that. The last one I want to talk about is just called a venography. So it's basically taking a picture of the veins in our legs, and we usually do this in the deep veins of our legs. The reason we do this is to assess for the presence of any DVT, or deep vein thrombosis. So we want to see, are these veins working? Do they function well? Or do we have any sort of thrombosis in those deep veins? So we can really look at the patient. We do this imaging of these legs, and we assess what's going on with the patient's deep veins in their legs. We can also use this to assess for a vein that we would maybe want to use for a CABG, for an arterial bypass graft, something we could take from the deep veins of the legs, bring up into our heart, and use as a vessel for there. We're going to want to monitor closely our puncture site, because we're going to use contrast medium for this. Okay, so we want to first of all, of course, assess the patient for any allergy to contrast medications or iodine allergy, anything like that. And then we also want to monitor the puncture site to make sure there's no hematoma, make sure there's no hemorrhaging. And then the biggest thing we're going to do with this is we're going to take this, a radiologist, cardiologist is going to read this. We'll be able to say, yes, patient has a DVT or doesn't have a DVT. And that's really what we use a venography for, is to see, what's the functioning of those legs. Do you have any sort of stasis issues for this patient? All right, guys, so that's 10 common cardiovascular diagnostic studies you're going to see that'll help you to be just basically familiar with. I know we didn't go into a lot of depth with this, but hopefully this gives you a basic understanding of some of the more important ones, some of the ones you need to understand, even if you don't get to see it very often. All right, guys, I want you to head over to nrsng.com/freebies, and you'll get signed up for our free Friday freebie emails that we send out every week with a different cheat sheet, different PDF guide, reference sheet that you can use on the clinical floor. You guys, thank you so much for being part of the NRSNG family. I appreciate you guys being here. We are here to help you. We want you guys to succeed. I know that sounds corny. I know that sounds cheesy, but whatever. I'm appreciative of everything that you guys are doing. I know the stress of nursing school. I know the stress of starting a new job as a nurse. I know the stress of preparing for nursing school. Okay, I've been there, and we really want you guys to succeed. So thank you for being part of the NRSNG family. If you guys need anything, reach out to us on social media. Reach out to us over email. We will respond to your email, and we want to see you guys succeed. So thank you. And we will talk to you soon. But you guys know what time it is now. It's time to go out and be your best self today. Happy nursing.